Today's topic, we are talking about IGF1 deficiencies and its relationship with insulin resistance, metabolic syndrome, diabetes, fatty liver disease, whatever. So I get my inspiration for questions and topics based on what patients ask me and conversations I have with patients. So let's dig deep. In clinical practice, this is probably the most common cause that I see of low IGF1, which is insulin-like growth factor, is diabetes and or insulin resistance, or like I said, fatty liver disease is another metabolic disease that can cause low IGF1. Now, roughly about a third of Western populations are afflicted with one of these metabolic diseases. Whatever you refer to it as, regardless, it's going to lower the IGF1 in the patient. And it makes absolute sense that IGF1s would be low in patients that do have these metabolic diseases, because if you think about it, or if you know, IGF1 has 50% of the same homology as does insulin. In other words, essentially 50% of insulin's amino acid sequence is exactly that of IGF1. And furthermore, IGF1 does have the same effects in terms of glucose disposal as does insulin, albeit it's about a 1/10, 1/12 ratio of efficacy. In order to understand the phenomenon in terms of IGF1's relationship with metabolic disease, you need to understand the physiological role of how IGF1 is produced and how it functions in the body. Okay, so when the hypothalamus stimulates the anterior pituitary gland to release growth hormone then stimulates the liver to produce IGF1. Now, the liver is roughly about 75% of the source. It's about 75% responsible for total IGF1 in the body. And the other 25%-ish comes from peripheral autocrine/paracrine activity. Some of that autocrine/paracrine activity typically occurs in the joints and other peripheral tissues. Now, this stimulation on both facets, whether it's the autocrine/paracrine or the liver's production, that stimulation is attenuated when IGF1 reaches homeostatic points for that patient. Now, when I say homeostatic points for that patient, everyone's different. But in this case, we're just talking about what's specific to that patient individually. Now, this process is referred to as a negative feedback process. Now that you have an understanding of how IGF1 release is stimulated, let's talk about growth hormone's role in glucose/triglyceride disposal. Okay? So GH stimulates two principal enzymes. Well, there's an exorbitant amount of enzymes, but what we're talking about today are two enzymes in this context. Anyway, hepatic lipase and lipoprotein lipase. Now, these enzymes are responsible for facilitating the breakdown of triglycerides and therefore the subsequent release of free fatty acids, which will then go to the liver for disposal. Now, by breaking down these triglycerides, what you're doing is you're preventing a large influx of free fatty acids from flooding the liver, which, if that would have occurred, and over time, those free fatty acids that would have flooded the liver could have contributed to the development of fatty liver disease, which is also known as NAFLD or hepatic steatosis, whatever you want to refer to it as, insulin resistance, diabetes, metabolic syndrome. I think you get the picture. Also, GH also stimulates lipolysis in adipocytes, and it does this by upregulating catecholamine activity in the fat cells, which thus upregulates adrenergic receptors in the fat cells. Furthermore, growth hormone also has antagonistic effects on insulin. While insulin does promote triglyceride and lipid storage, growth hormone, it opposes these actions of insulin. Obviously, growth hormone also stimulates the activity of IGF1, and IGF1 in this context would stimulate the uptake and oxidation of fatty acids and glucose, primarily, more preferentially in skeletal muscle. And also, as mentioned earlier, IGF1 has similar glucose disposal properties, albeit it's like roughly 1/10, 1/12-ish potency of insulin. But unfortunately, in states of metabolic syndrome or insulin resistance, you don't quite get these benefits in terms of glucose disposal or of triglyceride disposal of the activities of GH and or IGF-1. This is actually one of the primary underpinnings of why people have fatty liver disease, because they cannot sufficiently dispose of triglycerides and or glucose within the liver, which ultimately this leads to an accumulation of fat within the liver. Thanks for watching, and hopefully this video was enlightening and brought some new information to you regarding the pathophysiology and the relationship of IGF-1 and metabolic disease. If you have any other questions, hit up Steve Devos. Let him know what you want to know. Appreciate it.